Good evening, everybody. I'm Professor Mario Cozzolino from University of Milan, Italy. It's a great pleasure for me to chair this section on hemoabsorption in chronic hemodialysis. And we thank Jaffron to organize this. So also I would like to invite people that are in the back of the room to come, because this will be really informal presentation and discuss about clinical data on this technique. So I would like then to start the meeting and introducing Professor Claudio Ronco. Then we'll give the first presentation, and Claudio will talk about inflammation mitigation hypothesis. Thank you, Claudio.
Thank you very much. Here is my slides. I'm very happy to be here with you today because this gives me the opportunity to speak about a concept that I think I've been working in the last 25 years or so, which is the concept of the importance of inflammation in chronic dialysis. So we are dealing with chronic patients that have more and more advanced age. They are sicker, comorbid. Suboptimal middle and long-term outcomes are present, and in a limited resource environment, such as healthcare system, poor outcomes, complications, and hospitalizations affect cost. Complications are associated with retention of specific molecules, and we know today that retention of these uremic solutes expose end-stage kidney disease patients to a high burden of inflammation and cardiovascular disease, which are somehow linked in a vicious circle. Now, the story is now unfolding because we have learned that specific molecules are related to specific symptoms and complications, such as serum amyloid A or beta-2 microglobulin or PTH, homocysteine, leptin, etc. And all these are now telling us the story of what uremia is. We are dealing with small molecules, and ureakinetics has been extensively studied in dialysis, while the role of middle molecules has been a little bit neglected, although Belden, Scribner, and Babb in 1966 already described the square meter hour hypothesis. So classifying uremic toxin is important according to molecular weight, and as you can see, in the area of middle molecules, we have small, middle, and large molecule, and we end up with essential proteins, including albumin. But this has a very high binding capacity, which includes, in the theory of uremia, the protein-bound solutes. Some of these solutes are in the specific range between 10 and 50,000 Daltons, and you can see here from the proteomic assessment that these molecules are accumulating and somehow leading to specific complications in different organ systems, including kidney, cardiovascular, endocrine, immune system, gastrointestinal, neurological, etc., etc. We have recently published a new classification of uremic toxin in JSON and we were able to somehow link the inflammatory effects of these toxins, such as cytokines, adipokines, growth factors, immunomediated proteins, etc., where typical example of different molecules are present, and the effects are a kind of accelerated atherosclerosis, anorexia, cardiac hypertrophy, etc., including immunological derangement. We are very well aware that, for example, interleukin-6 levels are much higher in patients on end-stage kidney disease compared to healthy controls. We know that C-reactive protein is higher in dialysis patients, and this may affect the outcomes, especially today that we know that high sensitivity CRP is what detects the level of CRP in the very low specific range. We know, for example, YKL-40 is an inflammatory mediator associated with increased mortality in HD patients, and the same is true for polyclonal free light chain in CKD patients. So once you know that, you can draw a map, and this is part of our publication in CJSON, when we clearly describe what are the methods in dialysis that can allow you to remove specific molecules. And as you can see, when you're talking about protein-bound solutes or large middle molecules, there are very, very little modalities that may allow you to remove these molecules. We know the limitations of diffusion. Diffusion coefficient decrease with the increase in solid molecular weight. We know the limitation of convection. Sieving coefficient of membranes are characterized by a specific drop in permeability and sieving coefficient, even with the most recent high retention onset membranes. And we know that dialysis membranes are mostly characterized not only by pore density, but also by pore size distribution, which has been something we have been working recently with the so-called high retention onset membranes that, as you can see here, have a much steeper sieving coefficient compared to classic high flux membranes. So where diffusion and convection cannot let's say, allow removal of larger molecules, you might need to add a specific method of mass separation, which is adsorption. Sorbents have been known for more than 1 century, and they were originally natural and synthetic. Today, they're mostly synthetic. They are polymers that act on direct adsorption or anion and cation exchange, immune adsorption, and they come in fibers, granules, or beads, and they can be macro, meso, or microporous. Again, the structure of the sorbent, as you can see here, may have a different spectrum of pores that allow to remove different type of molecules at the inner side of the structure. And depending on which target molecules you want to remove, porosity can somehow be targeted and specifically designed in sorbents dedicated to a specific action. So small, middle molecules and large molecules can be removed thanks to a kind of enhanced porosity, which is controlled by a nanoscale molecular sieve control. The dynamic forces involved are hydrophobic bonds, ionic bonds, van der Waals forces, and hemoadsorption today overcomes some of the limitation of the classic membrane separation processes. But you need this effective and safe sorbent material, stable, hemocompatible, good design of the unit with excellent flow dynamics, and no, let's say, activation of clotting or side effects. We have studied modern sorbent, like in the case of the Jaffron polystyrenic macroporous membrane, which has been surface coated to improve interparticle and extraparticle flow tendency of the fluid phase, which in this case is plasma water. Hemocompatible according to the static and dynamic test of viability, apoptosis, and necrosis, with excellent flow dynamics analyzed by CT scan. Every single component of the unit has been analyzed and studied, and therefore, at this point, coupling sorbent with a hemodialyzer in chronic patient may be an interesting option. There are studies such as these on more than 1,400 patients, where patients in which hemoperfusion was combined to hemodialysis and was compared to patients doing hemodialysis alone, in which significant improvement in beta-2 microglobulin, PTH, level of inflammation, cardiovascular event, and also all-cause mortality was demonstrated. Most importantly, this patient had a significant improvement in quality of life. The same type of analysis was done in another study on almost 500 patients, where, however, patients combining hemoperfusion with hemodialysis were also subdivided in patients doing high flux and low flux, and compared with similar group without hemoperfusion. And effect seems to be correlated to the addition of the sorbent rather than the flux characteristic of the membrane. In the safety analysis, there were practically no difference in the side effects, which were marginal in all the population studied. But the most interesting thing was that there was a signal at 2 years in terms of survival, showing that probably the effect on the major complication was affecting also survival. So we concluded in blood purification saying that this type of therapy may remove specific uremia retention products. They may improve quality of life, they may improve cardiovascular complication, and significantly improve the state of microinflammation and renal anemia. Today, indications for this type of therapy include inflammation, beta-2M accumulation, anorexia, malnutrition, pruritus, uremic syndromes, weakness, sleep disorders, osteoarticular pain, and in a series of papers that will be recently presented in a consensus conference that is organized by Professor Zhuo Li from Beijing, there are documented effects of improvement of several of these symptoms, including a reduced status of inflammation. Now, knowing very well that this sorbent can remove effectively in vitro pro-inflammatory, but also anti-inflammatory mediators, which are mediators of the immunodysregulation occurring, we have analyzed what happened in different inflammatory factors in patients doing hemoabsorption plus hemodialysis, and you can see a reduction in leptin, high sensitivity CRP, high PTH, TNF-alpha, beta-2 microglobulin, IL-6, and the serum concentration of these substances was definitely declined compared to the patient treated with hemodialysis alone. Also, we have demonstrated that HD plus HA can effectively eliminate inflammatory factors, and the clearance of these substances is much better than hemodialysis, just measuring before and after dialysis. And the other comparison was that utilizing specific sorbents cartridges with more sorbent in it, we were able to show that there is an improvement in the inflammation state with the bigger cartridge, showing that probably there is a dose effect. We also performed studies on beta-2 microglobulin kinetics for 4-hour session with HA plus HD, showing that there is a significant decrease compared to other type of dialysis therapies. And in a 3-session-per-week regime, there was a progressive reduction of the concentration of beta-2 microglobulin, starting from the first month, with the second month using only 2 sessions per week, and the third month using only 1 session per week. This was accompanied by the reduction of other inflammatory mediators and improvement in albumin, nutrition, hemoglobin, and reduction in necessity of EPO. This led us to create this concept of inflammatory mitigation theory, which is not only the problem of retention that may lead to a smoldering inflammation in classic dialysis due to accumulation and increased levels of beta-2 and other compounds. In adsorption plus hemodialysis, there is an increased clearance of these substances, together with the increased clearance of inflammatory mediators that also reduce inflammation and lead to reduced generation that allowed to treat the patient 1 session per week in the steady state condition. So what kind of patient is a real candidate? Well, to me, as an advocate for a patient, every patient should be candidate to prevent complication. But in the current situation, patients with mild symptoms may consider once per week regime of treatment of hemoabsorption plus hemodialysis, especially those patients who cannot achieve a very high blood flow. While patients with severe symptoms and frequent hospitalization may require to start with 3 sessions per week for 1 month and then to de-escalate to 1 session per week later on. Future sorbent characteristics already in the pipeline of the company present the possibility to have a specific sorbent dedicated to middle large uremic solutes, and finally to protein-bound solutes that show superior clearance of these different sorbents. I think there are studies now in the R&D group of the company that shows significant removal of protein-bound toxin by the new sorbent, including paracrasol and indoxyl sulfate. And as you can see here, again, different protein-bound toxins are removed very highly with the new PHA sorbent, which is not yet available here in Europe. So the quest for optimal renal replacement therapy and renal function in patients with chronic kidney disease moved from insufficient or no therapy and death to a kind of adequate dialysis. But we need to move to a further step, possibly leading to complete rehabilitation. Adsorption could be part of this new step. And if you look at the healthy status from a polyparametric analysis in a patient with normal GFR, you see that this is a kind of a radar graph where every criteria is respected. But if you look at the concept of entropy, which is the disorder in the biological system of the body, you see that specific disease, for example, accelerate the level of entropy in patients. What happened in patients in uremia? Several of these parameters are completely unsatisfactory and affected by uremia. And therefore, what happened is that the acceleration of entropy in the biological system is suddenly decreased and slowed down by the presence of dialysis. However, we need to have an adequate dialysis. We need to have a dialysis that is considered from a multidimensional approach, including reliability, availability, efficiency, KT/V, convection, tolerance, environmental safety, cardiovascular stability, automation, sustainability, savings, free time of the patient, quality of life, and feasibility. And if you look at the different level, standard dialysis, hemodiafiltration, long frequent dialysis, they all have specific advantages, but probably this type of therapy seems the one that satisfies almost all criteria for a complete rehabilitation of the patient. So we are exploring a new frontier using adsorption coupled with hemodialysis. Beneficial effect seems to be associated with mitigation of inflammatory status. We need to identify patient subgroups that are likely to benefit from this therapy, to establish adequate dose and frequency of the therapy, to identify target molecules and biomarkers to monitor the results, identify adequate endpoints for clinical trials, consider potential side effect or contraindication, to promote a full range of research to establish solid evidence, and we need to define cost-benefit ratio based on patient-centered approach. We need to offer dialysis patients a new option to improve their quality of life. I have to commend Jaffron Company for putting together the SALIN program, which is a kind of extramural grant program, putting on the table more than €1 million to fund studies in the area of adsorption. And the first round has been recently concluded with more than 60 applications from all over the world. There will be next year probably another round of application, and hopefully research will give us the answer to our many questions. Thank you very much.
Thank you, Professor Ronco.